Oh,
Okay, we are now recording. So, for starters, welcome everybody who is new here for this RES 257 class. Um, I invite as many people to this as I can, so that means that even after the end of this module, you guys are still invited to come to these lectures because you're at the point in time where you really need to be studying for your TMC exam. And so these lectures are completely geared towards the TMC exam. We really are just discussing the things that we expect to be on the exam. And we go over that kind of stuff instead of just stuff that gets you through a hoop to pass a class. And so a couple housekeeping things for RES 257. You have the code now to get into Classmates for this particular module. And I put that on the announcements yesterday. So please make sure you get in there and sign up and get going on it. You'll need to use the 12-digit code that you've had from previous modules. Also, that identifies you personally. And if you have a problem with that code, if you've forgotten it or never received one, anything like that, please let me know as soon as you can so that there's not a delay with you getting into that, because Classmates is really fantastic. As a matter of fact, some of the lectures that we do here are just going over Classmates. So we kind of alternate. We'll do those in a couple modules from now. We'll switch to doing Classmates for a while. Also, every module, there are one or two students who have a hard time uploading the PI forms to me. And I don't know if it's because you haven't done them before or whatnot, because you should have done them before. But please make sure you get them uploaded soon. So you're going to clinicals for 60 hours. You should have multiple physician interactions. And it doesn't have to be you sitting down on a couch and talking face-to-face with a physician, one-on-one with nothing else going on. It doesn't have to be anything as big as that. It needs to be a time when you were there with a patient, the physician was there, you guys interacted. I want to know what the physician wanted, what you did, that kind of stuff. But it would be ideal if you could get those turned in very soon. Uh, It'd be great if you got them all turned in by week 2. That way you just avoid the problems of trying to do them through week 4. But one note of caution, I do read what you write, and it can't be anything just like what you would put on a discussion forum. It needs to discuss the physician. I need to have the physician's name there and what the physician said and stuff, because it is a physician interaction form instead of a discussion post. So anyway, just make sure that you guys do that, get them turned in. And then if you have any questions, let me know, because we can discuss them here with these discussion forums. Okay, that being said, I have everybody on mute except it looks like April is not on mute right now. So if you want to talk to me, just make sure that you unmute yourself. And so for those of you that are new here, this is very open, meaning that if you have questions, I want you to stop me. Let's talk about it. We'll go over them. We usually finish this in 4 weeks. We are now at week 5, and we are just going to start talking about volume control and pressure control today. So we've deviated a lot, and that's great, because if someone has a question, that means a lot of people are going to have a question on it. So I don't care how long these go out for. I don't care if it's a 2-module, 3-module thing for it, because we're talking about things that you guys have questions about. And don't be shy. I'm not here to make anybody feel dumb. embarrassed or anything of that sort. I think we have a lot of fun with each other, and so it should be good. Okay.
Kevin, I have a really quick question.
Okay.
The physician interaction forms, are they allowed to use physician assistants, PAs, for those?
Yes.
Okay, the reason I ask is because I used to have, when I was going through school, I had to do my clinicals overnight, and it was very hard for me to get a physician overnight.
Yeah.
And I used a lot of PAs because they're always there.
Yeah, and that would work fine for me. I don't know what the official rule on it is, but the way that I think about it is they are physician extenders, and they're licensed individual practitioners. They can do anything that a physician can do, even though they have to be co-signed with a physician. I would absolutely accept that.
And sometimes they're more helpful than the physicians are.
Amen to that. Yes, very, very true. Okay, so you guys will notice on the schedule also for the live lectures that they are all over the place. And so I'm looking here. Looks like the next one is in a couple days at 8:10 in the morning. So my family and I are going to go on a vacation, and so I am just whittling them out so that I don't have to do it while I'm on vacation. I'm going to have limited internet and etc. And so we're going to get them all in. It's just that they're going to be, some of them are going to be before the time that they would normally come. So look at your schedule. I like to have them consistent. You know, these have been at 8:10 in the morning on Tuesdays for quite a while, but this module is definitely different. So.
Well, where are you going? We may have to follow you so we can do like a beach conference or something.
Well, we're going to go to the Redwood Forest in California, and then we're going to go up to Oregon. I have a brother that lives there, and spend some time with him, and he and I will go golfing.
Hey, I like
Quite a
Cali.
bit. So, yeah, it should be fun.
Let's go.
Should be a good time. Okay, yeah, we'll just carpool.
Do a mini
Yeah. That's awesome. We can have respiratory discussions all along the way.
Right?
Yeah.
You know, and isn't it harder to breathe up in California? I was there several years ago in La Jolla. I used to always go there.
Well, you must not have ate the brownies.
No, I didn't.
That's funny.
Uh,
Yeah, so it should
Too
be
bad.
good. I'm looking forward to the break, and
You
for
deserve
those
it.
of you who are in class, you really shouldn't see any difference. I'll still be getting on each day that I would normally get on. I usually only take like one day off each week, but I'll be answering emails and doing all that stuff. The only thing that you'll see different is that the live lectures are at kind of squampus times and whatnot.
Now, your next one is Thursday. I think the email that I got from you, it said that you have one Thursday evening. Is that correct?
It's Thursday morning at 8:10.
Okay.
Yep.
I'll see you then.
Let's see. Week 3 is next Tuesday, so a week from today at 9:20 a.m. And then these are all mountain time, so adjusted accordingly to whatever time zone you live in. So yeah, basically we're going to have 3 lectures starting with today, between today and next week. And then we won't have one again until July 3rd. So, and that one will be in the evening time.
I have surgery on July 7th.
Oh, you do?
Yeah.
I'm sorry. Well, I hope that all goes well for you.
Other than having to keep my legs straight for 2 weeks.
That doesn't sound good.
No.
Okay, so before we get into this, does anyone have questions? Anything that's been bugging you lately?
Okay, Kevin, it's Kathleen.
Hey, Kedley.
Hey, I scheduled my exam for the 21st for the RRT,
Okay.
but I feel like I need more time. I want to finish all of your lecture. You think
Okay.
I can do that?
Yeah, you would be the best judge of that. If you feel like you're not quite ready, then yeah, I'd probably wait just until.
Because it's a lot of print, and I'm afraid I might not get it in one shot, and I have to go back.
Yeah. Yeah. So yeah, maybe extend it a week or two, or a couple weeks at least.
Now, Kelly, you going back to get a higher score?
Yes,
Okay.
I think I should spend it a little more time. I'm scared.
Well, don't let fear dictate it. Go by really what you feel like as far as if you're knowing the answers to these things that we're talking
I'm
about.
getting good, but I'm still feeling a little bit shaky.
Yeah. Well, that happens to everybody, and that is definitely something that happens. So, okay, I guess if nobody has any questions, we're going to start talking about volume control somewhere around here. There we go. So just by way of review, before we get into this, remember the different pressures that we have. Remember that we have a peak pressure, okay, and that's going to be the highest point that it gets in. Let's see if I can do this. Oh, I need to switch to a pen. So in this graph here, you would see that this right here is the peak pressure. Okay, down here is the PEEP, that's our baseline. That has a major effect on oxygenation because it will increase our mean airway pressure greatly. Because anytime that we're not taking a breath, we're at the baseline, which is where our PEEP is. And then this little guy right here, this measurement from PEEP up to the top is our inspiratory pressure. Okay, remember that this is the same thing as our tidal volume, okay, because that's the pressure that's pushing the air into our lungs. So if we are in pressure control, and somebody's getting just a little bit of feedback. Let's see. It has to either be Denise or Kedley because everyone else was muted. Okay, so if you're in pressure control, you're either going to set an inspiratory pressure or a peak pressure, depending on what kind of ventilator you have, but you're still affecting the same thing. You're still saying, I want you to go this much above PEEP. Okay, and that's how you set the size of breath that you're going to give. Now, if you're in volume control, you'll set the tidal volume. And remember that the other thing is variable. So if you're in pressure control, you set the pressure. It says, I'll give you that pressure, but the tidal volume could be variable because patients have different types of compliance. Okay, now if you're in volume control, you can set the tidal volume and it'll say, yep, I'll give you all of that tidal volume, but this patient could be really compliant or this patient could have really stiff lungs. And so I can't guarantee how much pressure it's going to take for me to get that in there. Okay, and those are the two major differences between pressure control and volume control. There are definitely other differences, but for the sake of our discussion right now, that's as far as we're going for a few minutes. Okay, so most people have a hard time remembering inspiratory pressure. They get peak pressure and they get PEEP really well. It's just that inspiratory pressure. And sometimes they get it confused with each other, inspiratory pressure and peak pressure. But they're definitely different. Okay, let's go ahead and get into assist control. And I'll tell you what, let's just do some blank pages here. Okay, when we are in, and I say assist control, but I'm meaning volume control, assist control. Okay, so when I say assist control, I'm just synonymously meaning that as volume control unless I tell you it's pressure control, okay? So we are in volume control, assist control, And I'm going to separate this. We're going to work above the line here. Draw a bunch of windows. Well, let's do it like that. Okay. If we say that we are going to have a tidal volume 500, respiratory rate is 10, PEEP is 5. Okay, so that's 5 centimeters of water pressure. You're going to notice here that I have pressure and volume on the same line here because I'm going to use this as 500 milliliters or 500 cc's. It's the same thing. Okay. And so I'm just going to draw this baseline across here. Okay, so we have a patient and they are parked at 5 centimeters of water pressure for the entire duration, except for when they're taking a breath. Okay, now I have a respiratory rate of 10 breaths per minute. What does that mean to us as far as how often we're going to take a breath that's mandatory? And remember that you need to unmute yourself to talk. So respiratory rate of 10, the patient is riding the ventilator. How often is the patient going to get a breath?
Whenever they meet what you've set for them.
Okay, that is true. So now we're looking at the respiratory rate. So when I say respiratory rate, what does that mean? 10 what?
There's only 4 box.
Well, when you're talking to a physician and you're giving a report of the respiratory rate, you say respiratory rate is 10, and then there's 3 words that you say after that.
It's how much their respiratory rate is,
I'm over here just looking.
how much they're breathing per minute.
Yeah,
Good,
BPM.
Yes, breaths per minute. Excellent. Okay.
Oh,
So that's what I'm getting at.
Okay.
So respiratory rate of 10, we need to be specific of when that time frame is because, you know, if we have 10 breaths during an evening, the patient's not going to be alive. If we have 10 breaths every 10 seconds, that's not good for the patient. So it's 10 breaths per minute. Okay, so now I know that I am assigning this patient to breathe 10 times per minute. And it's going to separate these breaths out evenly. So how many seconds apart is each breath? If we have 10 breaths per minute,
2.5. Right?
okay, it's going to be longer than that. But keep going. I don't want you guys to, I don't care if we get wrong answers because we're going to come to the right answer. This is
I repeat the question again.
Okay, so our respiratory rate is 10 breaths per minute. And the patient's riding the vent. We don't have to deal about it with any extra breaths. So it's 10 breaths per minute. It's going to divide them out evenly. How far apart is each breath going to be? From beginning of the breath to the next beginning of the breath.
Wouldn't you divide 10 into
6.
60? That'd be 6
6
seconds.
breaths.
Perfect.
1 breath per second.
Yeah.
Oh, I got it right.
Yes, you did. Okay. Okay. So April got it right too, and she said that. Okay. So April, you are muted. I'm going to unmute you. Now say something, and let's see if we can hear you.
Easy.
Okay.
April?
You divide 60 by 10 and then you get 6.
Okay. So April must maybe it's not working with microphone or whatnot. So feel free to write your answers in the chat, and I'll watch that too. So April got it right also. So that's correct. All we're doing is we're taking 60 seconds and dividing it by the respiratory rate. Okay, so we take 60 seconds and divide it by 10. That gives us 6 seconds per breath. Okay, and we call these windows. So that means each window is 6 seconds. Okay, so I'm just going to write this, actually just write down at the bottom so I don't get it in the middle of everything. Okay, so 6 seconds there, 6 seconds there, 6 seconds, and this one's going to be 6 seconds too. And we're just going to make that about the same size as the others. It looks like it's still bigger than the others. Okay, so 6 seconds per window. All right, so we are delivering a tidal volume of 500 cc's. The ventilator says, no problem, I can do that. By the way, I didn't write flow here. I'm just going to say flow equals 60. That's a pretty good number to start with for flow. So the patient is parked here on 5 of PEEP, okay, not doing anything, and now all of a sudden they're into a window, into the beginning of a window, and the ventilator says, it's time for you to have a breath. So it gives the patient a breath. It gets up to 500 cc's, okay, and it's volume cycled. It's volume control, but volume cycled, meaning once it gets up to that volume, it cycles. In other words, it turns itself into exhalation. And so it goes up, and then you get the breath coming down like that. Okay, so it gets to the next window, and nothing's happened since then. It says, oh, it's time for another breath. So let's go ahead and give you a breath, and we come down. Okay, I'm going to give you another breath, and then we come down. Another breath, then we come down. Okay, that's what the ventilator is going to do if we're not breathing any faster than the ventilator. Okay, in other words, let's say we have a comatose patient, and now the patient is just riding the vent. Vent is doing all the work, and this is what you see. Okay, so a few things on this. First of all, I said that the patient's riding the vent and the vent is doing all the work. I don't want to lead you astray, because the vent is going to do all the work for you every single breath. Even if you are breathing spontaneous above the minimum respiratory rate, the vent is still going to do the work for you. Okay, so what happens if this patient wants to breathe faster than the ventilator? The ventilator will say, hey, that's fine. I'll give you more breaths. You want them, I'll give them to you. Okay, but what happens is all of a sudden you see this little notch down here with the pressure, because remember this bottom part right here, it's 5 of pressure. And so we're kind of using this as a volume and a pressure loop here, or breath here. So the ventilator would see a negative deflection in the pressure loop, showing that the patient's trying to take a breath in. In other words, they just sucked some air out of that circuit. The ventilator recognizes that and says, oh, the patient's trying to breathe. Okay, so then the ventilator kicks in and gives a complete breath, meaning that the ventilator doesn't say, okay, go ahead and take a breath, take as much as you want. The ventilator says, you want a breath, I'm going to give you the entire breath. Okay, so this is 500 cc's, same as this one. That's 500 cc's. Those breaths look exactly like each other. They're supposed to. And the only reason why we know that this is spontaneous, well, first of all, the ventilator tells us. But you can see on the pressure breaths, when you're measuring the pressure, that you'll see that little deflection down there. Okay, so if the patient wants to take twice as many breaths as that, or 3 times as many breaths as what's said on the ventilator, The ventilator is fine with that. It'll let the patient do it. It will breathe as fast as they can possibly breathe. Okay, now we're going to get into problems if they're breathing so fast that they don't have time to exhale completely. We'll get into breath stacking, and that does happen sometimes. But the ventilator basically says, I am your servant. I will do whatever you want me to do. Just know that every single time I give a breath, I give a breath of 500 cc's, whether I instigate it or whether you instigate it. Okay. Does anyone have questions with this? Don't be shy.
All right, I do have a question.
Okay.
Surprise, surprise. So you see your first shark fin, it looks like where it goes up and goes down. Your inhalation and exhalation there.
Are you talking?
And then
okay, right here.
Yeah, and then
Okay.
go down, exhale down to your deflection point.
Okay.
And then the patient says, okay, I want another breath. And so they start taking that breath.
Uh-huh.
But I don't know if I'm going to explain this to where you can understand what I'm talking about. Say they start to take the breath closer to the next box over. And they start to inhale and they get 250 in, but it's time for their next breath to take over.
Uh-huh.
Will the ventilator then give them an additional 500 or only go up to?
So,
Did I explain?
yeah, in other words, are you saying, will the ventilator give them 750 since they've already done 250? Is that what you're asking?
That I don't know if I.
So
No, not really. If they start to inhale next and they get to 250, and then the ventilator says, "Oh, it's time for another breath," that the ventilator is supposed to give.
Uh-huh. So I think that I know what you're asking, and if I don't answer it, then redirect me and we'll discuss it further. So if they are in the middle of the breath by the time the next window comes,
Yes.
the ventilator is not going to interrupt that breath, first of all. So now the ventilators from a long time ago, they weren't as smart as the ventilators are now. But these are all synchronized breaths, meaning that the ventilator keeps track of what's going on, and it says, hey, I'm not going to give you two breaths at the same time. I'm not going to purposely breath stack this patient, etc. So what would happen is the ventilator would just let the patient finish that breath, and then it would give the next breath immediately after. So if that second breath, the one that's spontaneous, say that went into the next window a little bit.
That was going to be the next question.
Yeah, then the ventilator would say, okay, finish that one because I have another one coming for you.
Okay, so no matter what, they're going to get a breath. They're not going to be, so say it's 6 seconds per window, and they use 1 second of that following window. That means that the ventilator is going to give them another breath. They're not going to be without a breath ventilator driven until okay, I gotcha.
Yeah, the ventilator will guarantee that we get a breath every window, no matter what. Okay, and I shouldn't say no matter what. I mean, really, I could kink the tube and it's going to try to give a breath and then it's going to hit the pressure limits. I mean, there's always something that we can do. But that's what the ventilator is there to do. It's to give you a single breath minimum every single window. And it will do that. Now, let's say, okay, so first of all, I don't want to confuse you guys with having two things on this graph. So I have the 500 cc's up here showing volume, and this is pressure. And it's really not going to be like that. You're going to have a volume and then you'll have a pressure one, and that would be completely separate. I'm just adding the two here so that we can do it on one graph, okay? So if that's confusing anybody, then I don't need to do it that way.
No, but April had a question here too. She says, what would you change? Would you change the sensitivity if that happens where they take so many breaths?
Okay, very good question, April. So sensitivity, if you have somebody who is like auto-cycling, it happens sometimes if you get water in the tubing, it'll automatically auto-cycle. Or just if your sensitivity is too low, it'll auto-cycle. And so if it is creating problems, meaning it's giving you breaths when it shouldn't be giving you breaths, then you would want to turn the sensitivity to a higher number, to where it takes, to where it's really not as sensitive. And yeah, that's an excellent point there. And that might be on your TMC exam, actually. Something of that effect. If it's auto-cycling, always check and see if there's water in the tubing, first of all. That could be one of the things that they'll ask you about. But your sensitivity, it's just too sensitive if you're auto-cycling.
Yeah, that is something I do remember from the test.
Okay.
Sensitivity and the water in the tubing.
Yeah, water in the tubing's a biggie. Because remember, Pascal's law talks about decreasing the diameter of the tube, and it has a major effect on the amount of air that can go through that tube. Okay, so one thing that I want to tell you or show you here is, okay, so this is window 1, this is window 2, and so forth. So let's say we get to this second window, but the patient takes a breath. So I'm showing you this deflection here for the pressure part of the bottom, and then it gives that breath, okay? That counts. The ventilator doesn't care whether the patient instigates the breath or whether the ventilator gives the breath on its own. All it has is a requirement that it will give you a minimum of 1 breath every window, and that breath is going to be targeted at 500 cc's in this situation. Okay, so whether the patient instigates the breath or not doesn't matter. What matters is that they get that breath during the window. Okay, so in this second window, the patient triggered the breath was given, and the ventilator says, my requirement is satisfied. I don't need to give another breath in this window.
Is that because it started at the window time?
It's because the patient took a breath in that window. And these windows are fixed times. Mm-hmm. So if it happened, if it happens here, that doesn't count. So think of the beginning of these windows, and these are just the vertical lines that I've drawn up. Think of them as the start of a race. Okay, you have everybody there. They're in they're all kneeling down. They have their foot plates behind them. And if somebody starts before that gun shoots, it doesn't count. Okay, but as soon as that gun goes off, they want to be going for it. Okay, so this beginning of the new window is a trigger for the ventilator that says, oh, time to give another breath. And the only thing that will really change that is if they're in the middle of a breath already, it's going to let them finish before it gives the next breath.
Okay, so what keeps the ventilator after the patient initiates that first one on the number 2 here?
Okay.
If the patient initiates it and does it, then it automatically says, okay, that's your breath for that window, and we'll do it the third window, I'll start it. Or if the patient needs it again, then the patient will start it again, correct?
Yeah. So just every time you get into a new window, that tells the ventilator, oh, time for another breath. Either you go ahead and start it, or else I'm going to do it for you.
Okay.
And the ventilator doesn't care. It's not here to take credit for anything other than that it gave the breath every window.
Okay. Now, is this where you would have like the respiratory rate is 10, but the patient's rate is higher?
Yeah, so as you look with window 1 and window 2, you can see that there are 4 breaths during those 2 windows. So during those 2 windows, the respiratory rate should be 1 breath every 6 seconds. But now you have an average of 2 breaths every 6 seconds. And so even though the ventilator mandatory rate is set at 10, if they continued on with that same, 2 breaths per window, that means that the actual respiratory rate would be 20 breaths per minute.
Right.
Okay. And we know that this patient is breathing spontaneous because the actual respiratory rate is higher than what the set rate is.
Right.
And the only way that's going to happen is if the patient's taking more breaths. Or maybe like April said, the ventilator's auto-cycling.
But now, if the patient starts taking more breaths than the ventilator has to give, are you going to change the mandatory respiratory rate?
Oh, good question. Because that's the direction that I was going to go next. Okay, so I'm going to let you guys answer this. Okay, so all of a sudden the patient is breathing 20 breaths per minute. No, let's say 30 breaths per minute. Okay, and we say, my goodness, that's a high respiratory rate. I have this set at 10. I'm going to drop it down to a respiratory rate of 8 for a mandatory rate. What effect is that going to have on the patient?
It's going to let the patient breathe more on his own.
Okay, what's it going to do with the actual respiratory rate, the total rate per minute?
Isn't it going to increase? Isn't the patient going to start to breathe faster because they're not getting a mandatory rate of what they want?
Okay.
But if they're breathing 30, I mean, how much of a mandatory rate do they need?
If they're breathing 30, why do they even need a mandatory rate?
Well, that's what I'm
now
saying, yeah.
you're getting close. Okay, so if I drop that rate down to 8, it will have no effect on the total rate. The patient's already breathing faster than they need to anyway, and the only work that the patient needs to do is trigger the breath. All they have to do is start taking a breath in, and then the ventilator kicks in and does all of the work, every single bit. Okay, it doesn't say, oh, you're giving me a half effort, so I'm only going to give you half effort on my part. It doesn't do that. It says, you want a breath? I'll give you the entire breath. Okay, so whether I have this rate set at 29 breaths per minute or 8 breaths per minute, it's going to make no difference in this situation because the patient's breathing 30 times per minute. They're over breathing the ventilator, and the ventilator says, I'll give you as many as you want. All you have to do is ask for them. Okay, so, and you'll see this a lot of times. A patient will be breathing high. So let's say the respiratory rate's 30 or 35 or whatever the case is. And they're on assist control, and the physician will say, oh, well, let's decrease the rate. You don't do that. It's going to have no effect on the patient. I could turn the mandatory rate off, and this patient would still breathe 30 times per minute. Okay, now that's not safe to turn it off. We're not going to do it. But it brings out the point that this patient's over breathing the ventilator. They're breathing faster than what the ventilator says you have to have. And so if I say you have to have 10 or you have to have 8, They don't care. They're breathing 30.
Couldn't you increase the tidal volume some so they get a deeper breath?
Oh, now you're thinking really deep now. You better be careful or else you're going to get a good score on this TMC exam.
Shoot, that's what I'm hoping. But this kind of goes back to what we talked about last week.
Okay.
That question that we spent that whole hour on.
Right. Okay, so here's the answer to that. Yes, sometimes that's what you need to do. So let's think about how you're breathing right now. Everybody's breathing whatever tidal volume you're breathing, okay? But you're breathing something that's comfortable for your body, that your body says that you need. So remember last week we talked about tidal volumes and how your body adjusts the tidal volume. So you're sitting down listening to a lecture right now, and you're probably just breathing pretty comfortably, not very big breaths, etc. But if you were to start exercising, you're not thinking about it, but your body's going to start breathing faster and deeper because it needs more minute ventilation.
Oh, no, I'm breathing faster right now.
My stress level might not be quite as high as yours right now. So I get that. So here's the thing. If I were to take you right now and say, here, let's match you with a straw that's perfect for your tidal volume. Okay, we'll make it as big as it needs to be to where you're not feeling any resistance. And you're going to breathe just like normal. Now I'm going to give you a smaller straw, and the only reason why I'm doing that is just so I can limit your tidal volume. But now you're not able to take as big of a breath. You're going to counteract that by breathing faster, right? If I say, oh, you can only take half the breath that you've been doing, you're going to start breathing faster because, your body's just going to do it. It needs that air in it, and so it's going to compensate. Okay, so yeah, the answer is, that was you that said it, right, Vicki, that asked that question?
Yes.
Yeah.
Okay, so the answer is yes. A lot of times that will fix things. If the tidal volume is set wrong, the respiratory rate will go up if it needs to, like if it's a small tidal volume, because your body doesn't necessarily care about how big the breath is or how many breaths per minute it gets. What it cares about is how much alveolar minute ventilation is happening to keep the CO2 in its normal range. Now, you may care about it psychologically. It's going to be driving you nuts. Okay, but your body is interested in keeping that pH level at 7.4, and it does that by controlling your CO2 in the short term. Now, that's not the only thing, though. A lot of times you'll have like a neurological case, and the patient's going to breathe fast no matter what you do, whether it's big tidal volumes, small tidal volumes, or not. So you just need to be aware of your patient's situation. And if it's because the tidal volumes are low and you're able to go higher, then that may fix it. Just remember that you need to keep pressures in mind too, because if this is an ARDS patient, you're not going to be able to go up very high on the tidal volume because their pressures are going to be extremely high.
So if they're maxed out on the tidal volume, say for their ideal body weight, they can get up to 700, and you increase the tidal volume to 700, and it's helped a little bit, but they're still, say, breathe in 25 times a minute. What would you do at that point?
Completely depends on your situation. So if you're able to go up higher on tidal volume, say your pressures are 20, then yeah, you have some room that you can go up higher. If you have an ARDS patient, maybe their pressures are already 30, 35 or higher, then you need to think about a different strategy, because sometimes you just can't deliver the tidal volume that they need, because if you do, you're going to blow holes in their lungs. And so If that's the case, then you need to start thinking about going to pressure control so that you
I was
can
gonna
have
say, you have
a
to
lung
switch the
protective
mode at that
strategy.
point. Yeah, okay.
Yeah, if we're talking like an ARDS patient, yeah, that should, anytime you're talking about somebody, if they say ARDS or they have low compliance, and make sure you know compliance levels. And so if they have a compliance of 60, is that good or bad? If they have a compliance of 20, is that good or bad? Okay, 20 is a horrible compliance, and that would be an ARDS type patient. But anytime you see those types of things, you need to be having in the back of your mind that you have a lung protective strategy coming ahead.
That makes sense.
Okay. Any other questions with this? Okay. Gosh, I'm just trying to debate whether we want to go on to the next one or not. Okay, let's talk about CPAP with pressure support. And then we'll probably end after that. We definitely don't have time to get into pressure control. And then next Thursday, when we have our next lecture,
This Thursday.
or this Thursday, sorry, we may go over some of this again because you just need to see them all three together. It's so much easier to talk about our volume control stuff all together. So if we have CPAP with pressure support, it's a whole different kind of breathing. So here's your, that's going to represent a few windows. We have CPAP equal to 5, pressure support equal to, let's say, 20. We don't have a respiratory rate because you don't set a rate in CPAP. And we don't have a tidal volume because you don't set a tidal volume in CPAP. So if we have CPAP of 5, and the patient is not breathing at all, where are they going to be sitting for this whole duration?
At 5.
At 5. They're going to be sitting at 5. So this would be similar to like a patient who is on CPAP at night. Okay, all that CPAP machine does is it tries to keep the pressure at the constant, which is whatever it's set at. In this situation, it's 5. Okay, and so the job of the ventilator is just to keep that pressure at 5. And they're not breathing in, they're not doing anything, so it's pretty easy for it to do it. Okay, now here's where it gets just a little bit trickier. So pressure support is set at 20. So that means I need to come up here. We'll call this 25. Now this is all pressure. This has nothing to do with volume. Okay, on this graph that we're drawing. So the patients here, they're parked at 5. All of a sudden, they say, oh, I want to take a breath in. Okay, so they take a breath in. You see that little trigger there. The ventilator recognizes that as a patient trying to take a breath in. And the ventilator says, oh, okay, you're trying to take a breath in. I am going to give you an extra 20 centimeters of water pressure because that's what our pressure support is. And I'm going to help give you that breath. So it starts giving you that pressure, and it goes up like this, and it gets to that 25, and the patient says, oh, thank you. They go into exhalation, and there's your breath. Okay, this is not 25, or this is not 500 cc's. I don't know how many cc's it is. What I do know is it is 25 centimeters of water pressure total. Okay, that's from 0. If I do it from PEEP, that means it's 20 centimeters of water pressure of a breath. Because my pressure support is 20. Okay, now if that's too big of a breath, I can dial down my pressure support. Pressure support is saying, I want to give you this much extra pressure every time you take a breath in. Okay, you're parked at 5, which is what our PEEP is set at. And then you take a breath in and it gives you 20 centimeters of water pressure. Now, CPAP is a stingy mode in comparison to assist control, because CPAP says, I'm going to help you as long as you're helping yourself. Okay, so if this patient is coming along here, takes a breath in, and it says, oh, here's my 20 centimeters of water pressure. It starts going up, and then the patient stops trying to take a breath in. It says, hey, forget you. I'm not going to help you if you're not helping yourself. Okay, so, and really you're going to see the curve go up to 20 because it goes up to 20 quick. But what you're going to see is, as long as the patient is trying to take a breath in, it will give you that extra pressure support. But as soon as the patient stops trying to take that breath in, that's what cycles it into exhalation. Okay. Now, the way that it does it, and don't fret over this part because I don't think this will be on your test. I'm just doing this so that you can understand a little bit better. You have what's called termination sensitivity. Okay. And usually on a ventilator, it'll be set at like 25%. So what it's doing here is it's measuring everything. It knows everything that's going on with this breath. And if the patient takes a breath in, let's say they take it in at 80 liters per minute, that's the flow. And it's just what the patient's demanding. That's how much they're breathing in. It says, okay, your peak flow was 80 liters per minute. So that means I have the termination sensitivity set at 25%. So once that flow decreases to where it's 25% of the peak flow, I'm going to cycle this into exhalation. Okay, so if you pay attention to the way that you breathe, I just took a big breath in here. You breathe faster at the beginning, and you're breathing faster through a lot of that breath, but once you get near the end of that breath, your flow slows down. And that's because your lungs are getting full and you're just not able to keep breathing in forever. Same thing happens with this patient here. The flow starts to slow down when they get near the top of what they want for their breath. And so once it drops down to 25% of the peak flow, the ventilator says, oh, they've had as much as they want. Let's go ahead and cycle it into exhalation. So I'm going to cross out this breath, and I'm going to draw the breath going up to 25 each time. The thing that is variable here is this might be 700 cc's. This one might be 400 cc's. Just depending on what the patient wants. If they keep breathing in, keep that negative pressure in their lungs, or trying to create that negative pressure in the lungs, the ventilator is going to say, hey, that pressure's dropped below what it's supposed to be. I'm going to increase the pressure so that you can get that 20 of pressure support. And that just gives them a bigger breath. Okay, think of your own breathing. You can take a small breath or you can take a big breath.
And when you say big, you mean deep?
Yes. Yep. Sorry. I mean a deep breath.
So why would you change them from like an assist control to CPAP?
Okay.
The CPAP, the patient's doing more on his own, right?
Yep, that's correct. So so first of all, I wouldn't put a sick patient on CPAP. If they need total ventilatory support, they're going to be on assist control. Okay, but as the patient starts to improve and we want to start weaning the patient, that's when we would switch them to CPAP.
Okay, when you said the patient was at the bottom, when you started drawing the graph, and you said the patient isn't breathing at all, I'm going, wait a minute.
Oh, yeah. Yeah, so that didn't, I just wanted
Okay.
you guys to know that there is no respiratory rate set for CPAP, and that they
I gotcha.
sit at the PEEP, whatever the PEEP is set at.
Okay.
Okay. So CPAP, if you're going to have a patient on CPAP, they need to be breathing spontaneously. Okay. If they're not breathing, you don't put them on CPAP because there is no respiratory rate. Okay. So assist control will give you complete ventilatory support. It's going to do all the work for you. You don't have to take extra breaths if you don't want, but if you do want to, go ahead and take them. But as soon as you trigger that, the ventilator is going to kick in and do all of the work for you. CPAP, first of all, it's not going to give you any breaths unless you instigate them. And it's only going to help you while you're helping yourself. And so CPAP is definitely a weaning mode. Okay, so and you can adjust how much work the patient is doing by adjusting the pressure support. You can turn that pressure support up, or you can turn it down. So usually, what you'll do is switch them over to a pressure support. You might go a little bit higher. Maybe you start at a pressure support of 20. And you look at the tidal volumes. And if they're really big tidal volumes, turn down the pressure support. You're giving them too much support. And so you can adjust those tidal volumes to where they're getting similar tidal volumes to what they were getting in assist control. And so maybe that takes a pressure support of 17 to do that. And that's great. Put them at 17. And let them work on it. They're increasing their muscle strength. And if they continue to do good and their tidal volumes continually go up, you can decrease the pressure support again. Or if it's opposite of that, maybe they get tired and their tidal volumes are getting lower and lower, it's time to switch them back to assist control, and we'll do some more weaning tomorrow.
Right, because this'll pretty much let you know, because like in the assist control, if they're triggering a breath, if they're over breathing the ventilator, then this will let you know kind of like what they're actually doing as far as they can initiate it, but this is also letting you know what kind of pressures that they're actually doing themselves, other than the assist control. When they trigger it, it takes off for them. Versus the CPAP is letting them do it on their own.
Yep, CPAP lets them do it on their own. Vicky wrote a good question. So if CPAP is patient dependent, then why use it for obstructive sleep apnea? Because it has a different purpose for that. So CPAP is there to help keep the airways open. But it's on a patient who is breathing spontaneous. So the patient is breathing spontaneous. All they are doing is they're breathing just like normal all throughout the night. It's just that we have increased the pressure that's in the airways, and so it's like keeping that balloon open. So a patient who has obstructive sleep apnea is trying to breathe. It's just that their airways are closed when they're asleep, and they've lost that muscle rigidity. And so they're trying to breathe, but they can't get any air because the airways are collapsed. And so the CPAP helps fix that.
So the CPAP would recognize that they're at least trying to make some type of effort.
Well, so we're talking different here. So
Okay.
CPAP alone, its only goal is to keep the pressure at whatever the CPAP is set at.
Because it's a continuous pressure, right?
Yes, yep. So if you take a breath in, it's going to increase the flow to you because you have decreased that pressure lower than what the CPAP is supposed to be set at. And as you exhale, it's going to back off on the flow because you're adding flow into the circuit. And it says, oh, the pressures are starting to go up higher than what I'm supposed to set at. And so it decreases the flow. So it's basically just a flow generator trying to keep the pressure the same. When we add pressure support, now it turns it more into a BiPAP machine. And it says, I have two pressures. I have a pressure when they're breathing in, and I have a pressure all the rest of the time. Okay, and so if you think of CPAP with pressure support as a BiPAP machine, that might help you
Distinguish between the two.
it might help it make more sense in your mind.
Right.
Okay, so one thing with this, the pressure support is a pressure control type of breath, meaning that you don't set a flow. The flow will be variable. So whatever the patient wants, the ventilator will deliver.
Gotcha.
Okay, so that part of it is a comfortable thing to breathe on. It's nice to know that you can get as much air as you want when you want it. Okay, any questions on CPAP with pressure support?
Now, you cannot overbreathe the CPAP with pressure support?
Well, you're overbreathing it the very first time you take a breath because there is no respiratory rate.
Okay.
And so it will give it to you as fast as you want. As long as you're trying to take that breath in, it will continue to help you.
Okay.
So respiratory rate can be slow or fast on this. And you need to keep that in mind. If you have a really slow respiratory rate, then chances are patient's not ready for CPAP. Maybe they're sedated and they just need that sedation to wear off.
Right, because the CPAP with pressure support, you only use on a patient who is actually, either overbreathing the ventilator, ready to be weaned, or spontaneously breathing on their own.
Yep, they definitely need to be spontaneously breathing.
Okay.
Now, if they're breathing too fast on it, then that could be an indication that they're not ready for it, that it's too much work for them, and they're trying to compensate by breathing faster.
Right, okay. But that would be like short little breaths, like breath stacking.
Yeah, usually, so the pressure would still go up to what the pressure's set at.
Mm-hmm.
It's just that the tidal volumes wouldn't be very big.
Right, okay.
That's almost like PSV.
Well, the breath is like pressure. So did you say pressure control or pressure PSV, pressure support ventilation? So this is pressure support ventilation. This is just CPAP.
That is. And then you could also do the SIMV.
Yep, and we'll talk about that one next time because SIMV is a marriage between these two modes that we just talked about. It takes some of each of those two modes and incorporates it into its own mode.
Awesome.
So Thursday we will talk about this, and honestly that might be all that we end up talking about. We'll see how far we get. I need to make sure that you guys know this really well. This is like
this is the part that this stuff trips me up every time.
There is a
All right.
that I see next time I will ask a question about it because it's a little bit confusing.
Yeah.
So I don't know if you want to go into this next Thursday or not, but I guess what I'm having trouble is you have your three, they look like little ghost men. You have a pressure support set at 20 and the patient inhales and then exhales and say they get I'm just going to your second little ghost guy, 700 cc's.
Okay.
But then the next breath, they're still getting pressure support of 20, but they're only getting 400 cc's.
Correct.
If they're going up to a pressure support of 20, why wouldn't they get the same amount each time of volume? Do you understand what I mean?
Yep. So that's a good question. And there's more than one answer for it. So first of all, if their compliance changes, that would change how big of a tidal volume they're getting. So, but the ventilator is giving that 20 of pressure every breath.
Why have to put it in the microwave?
And so it's trying to be consistent as it goes along. But the variable is the patient doesn't have to breathe in as fast or as slow each breath. So they can vary their breaths. So let me think if I can. Okay, so this is kind of a weird. Well, no, this will work. Okay, let's say you are breathing on a ventilator circuit.
Okay.
And the ventilator circuit is giving you 20 of pressure support. Okay. You can allow that pressure is going to be there no matter what. It's pushing in there. It's trying to push that 20 in there. But you can allow yourself to take a big breath with that. Or you can say, I don't want very much breath, and you can kind of push against it. Okay, so take partial breath in, but then start pushing against it because you want to exhale sooner.
I hate you, Zach.
Okay,
This is me.
let's see. I think that's Kettly. No, maybe not. Okay, so think about it that way. You're breathing on a ventilator. Okay, and it's giving you 20, you can say, oh yeah, let's take a big breath. And you just take a big monster breath with that. And it keeps trying to put more pressure in because as you take that breath, you're decreasing the pressure, right? Because you're sucking it in. And so the ventilator compensates and says, oh, I need to give you more flow to keep this pressure at 20 or 25 really, because it's 20 on top of the 5 of PEEP. And it'll just keep giving you that flow as long as you're allowing it to go in. Okay, now on your next breath, you say, oh my goodness, I don't want that much. But you start taking a breath in and the ventilator says, oh, let me give you that 20 of pressure support. But you're kind of pushing against it. You're not sucking in like you normally would be. And then you say, oh, it's time for me to exhale. And so your flow goes down lower and lower, and then it cycles into exhalation. That is you taking a big breath and you taking a smaller breath. But the pressure that the ventilator is giving you is the same.
I gotcha. Could that also be an indication that your lungs are becoming less compliant?
Yes, absolutely. It's a sign that so usually if you're seeing this kind of a thing, big breaths, so 700 cc's, maybe they're supposed to get 500 cc's based on their weight, then you would want to turn down the pressure support because you're giving them more support than they need. And so you're able to wean that pressure support. Now, let's say they're supposed to get 500 cc's and they're only getting 400 cc's. It could mean that their compliance is poor or they're just not strong enough to keep taking these breaths in. And pressure support will, even if you have the same exact pressures in pressure support as you do in assist control, because we can measure what the pressures are. We can see what the ventilator is giving you. Even if we give the exact same values, the patient will tire out faster in CPAP with pressure support than they will assist control. Because remember, assist control gives you 100% support the whole time. It does all the work for you. Where CPAP with pressure support only gives you that support while you're trying to help yourself.
Gotcha.
Is that okay?
Yes.
Okay. Anyone else
Thank
have
you.
questions? Oh, my pleasure.
So if they stay around 400 and you see that their compliance is decreasing, then that's when you would just put them back on your assist control?
Well, yeah. So if you dial them in to a pressure support that matches the tidal volume that they should be getting,
Right.
okay, so that's the first thing that we do. And then you watch the tidal volumes and the respiratory rate, and you're looking for good signs and bad signs. So if the respiratory rate stays in a normal range and their tidal volumes stay where they should or even get bigger, then the patient's doing good. Okay, and you would either keep them at that setting if the tidal volumes are where they should be, or if the tidal volumes are starting to increase, that means the patient's building up energy, they're taking bigger breaths, then you could decrease the pressure support, and that's weaning the patient. It's like adding more weights to the bar when you're bench pressing.
Right. So if it's
Could
going,
we also, sorry, Denise.
so if it's going the opposite direction, then they're doing poorly. So then you would put them back on.
You would either need to increase their pressure support, or you would need to put them back on assist control.
Okay.
If their tidal volume is decreasing.
Okay.
Now, when I say decreasing, I mean decreasing lower than it should be.
Right.
Okay, Vicky, you had a question?
Could we also think of pressure support as PEEP?
No,
Okay.
no. PEEP is the baseline,
Right.
and so the pressure support is what it's giving above that baseline.
No, she's thinking of like your peak, PEAK.
Oh, did you say peak?
No, I'm thinking of on the side where you have the 5 of PEEP at our baseline, and then you go up to 25.
Okay, so
See, when I see a bunch of numbers and information, my brain goes into overdrive.
yeah, if you, so you're asking a loaded question because there is a mode of ventilation where you have a PEEP high and you have a PEEP low.
PEEP
okay?
low, right.
And that's APRV. But this is definitely different than that because with APRV, without getting into it, because I want you guys to forget this as soon as I tell you, okay?
Right, because it's not on the test.
So if you are in APRV, you have a PEEP low, let's say it's 5, and you have a PEEP high, we'll say it's 25. So they're either at this one or they're at this one. They're one or the other all the time. Okay, but the difference there is they can breathe at this and they can breathe at this. And so it's a different kind of a thing. Where over here with CPAP, it's just using that to give you your tidal volume. So if you're going to relate it to anything, you could relate it to a peak pressure and the inspiratory pressure is 20.
Okay.
Yeah.
Does that make sense?
Yeah,
Yeah.
that's how I relate it. Like a peak PEAK pressure. Yes.
Yeah. So that would be a fair analogy to compare it like that.
Okay.
And you can tell what the inspiratory pressure is. I mean, the inspiratory pressure is 20. That's what your pressure support's set at. That's
Wow.
how big of a tidal volume you're going to get. It's just that same thing with pressure control. You can dial in the pressure, but that doesn't guarantee you how much volume you're going to get.
Professor Kevin,
Uh-huh.
and this is Kathleen again. You could use, is a fix, or you could use pressure support or CPAP or SIMV to win for winning,
Uh-huh.
or you could, or there is a fixed one.
So are you saying could I use either or to wean?
Yes, or
So it depends on your physician,
okay.
their philosophies. So yes, you can wean in SIMV. It's not as good of a weaning mode as CPAP. So the physicians in my area say, hey, basically they're saying, hey, poop or get off the pot. Okay, they're saying if you need support for this patient, keep them on assist control. If you're going to wean the patient, put them on CPAP. Okay. SIMV is kind of in between the two. And it's not nearly as good at weaning as CPAP is with pressure support. Okay, but there are times that SIMV is great. So first of all, your TMC exam doesn't care whether you use assist control or SIMV. They use both of those synonymously, meaning if the patient needs full support and you don't have a choice for assist control, but you do SIMV, SIMV would be an acceptable choice. But with SIMV, a good time to use that is, say you're weaning a patient in the middle of the nighttime, but they go apneic periodically. And so it's good to have that backup rate to give them a breath periodically to help remind them to breathe. So, and we'll get more into that when we talk about SIMV, but for those of you that are familiar with SIMV, that would be a great time to use it.
Awesome.
Okay, so let's go ahead and stop here. Next time we'll pick up at this place and we will get into SIMV, and then depending on how long it takes, we might be able to get into pressure control.
We're doing this Thursday?
Yep.
Yeah, this Thursday at 8:10.
Thursday, 8:10 a.m. Yep. Mountain
10:10 my time.
time.
Okay, I'm getting confused with the time. Anybody else live in Florida?
So if you're
All
in
right.
Florida, that means it's 10:10 your time. You're
Oh, okay.
you're 2 hours ahead of Mountain
Because
Time.
I was so late today, and I just want to kick myself. So
Because right now I'm in Virginia and it's 10:20, so you in Florida,
Okay.
you're probably the same time.
yeah.
Yep. So here's where we are. Let's say, okay, so I'm just gonna draw a box. Basically, here's our United States. Okay.
Draw a mountain.
So Pacific time,
Mm-hmm.
Mountain time.
I have to put it in my phone.
It looks like a pork chop.
Time. Hey, there you go. Makes you hungry. Okay, so if this is x plus 1, x plus 2, x minus 1. And so all you need to know is what time zone you're in. So Florida's in the Eastern time zone. Okay, so that means you're 2 hours ahead of what we are here in the Mountain time zone. Okay, so here it's 8:21 in the morning right now.
Okay.
Sound okay?
Yes. So Thursday, 10 o'clock.
Yep, that sounds perfect.
Yeah.
So, yep, that sounds good. And then I will see you guys then. If you have questions, really, I want you to feel free and comfortable to ask questions. We'll just keep talking about this, and eventually we'll get through it, and hopefully your knowledge will have increased. For those of you that have access to RT Board Review, keep going in it. It's a great thing for you. And for those of you who are in 257, make sure you take advantage of Classmates, one of the very best things you could be doing. So,
What is
Okay.
Classmates?
Classmates is a thing. Well, who asked that question?
Vicky.
So, Vicky, you probably weren't attending back when we were doing it. Classmates is a simulation that we go through. It gives us the examples, and we answer the questions, tell the physician what we're going to do. Sometimes we get them right. Sometimes we get them wrong. But then there is a audio that we can listen to with each section that tells us why these particular answers were correct and these ones were wrong.
I want to do that. I feel left out.
Yeah, we'll keep hanging with us, because when we finish going through these types of lectures, we'll go back into Classmates for a month or two.
I gotcha.
Okay. All right. It's been a pleasure. You guys have a wonderful day.
Thank you.
All righty, see you Thursday.
Sounds good. Thank you.